For a patient with advanced liver cancer, hearing the word inoperable can feel like a final verdict. But what if it wasn't? What if there was a way to build a biological bridge, one that could take a patient from an inoperable diagnosis to being a candidate for a cure? That's exactly what we're talking about today. We're going to dive deep into a fascinating new review that explores a technique doing just that.
Okay, so our guide for this journey is a 2026 rapid review led by Mohammed Moyanuddin. And this isn't just one team's opinion. What you're seeing here is how they did their homework. They sifted through hundreds of scientific papers and narrowed it all down to the 14 most important studies, which together cover more than 2,000 patients. So what we're looking at is a really solid, evidence-based deep dive into the last decade of research on this topic.
So here's our plan. First, we'll get a handle on the huge problem that surgeons are up against. Then we'll look at the incredibly clever solution that builds that bridge to surgery. After that, it's the main event, a head-to-head comparison between different treatment strategies. And finally, we'll wrap it all up with the verdict and, most importantly, why any of this really matters.
All right, first things first. Let's talk about the core challenge here. For these patients, surgery is the only real chance for a cure. But for the vast majority, it's just not an option right off the bat. So why not?
Well, this number really says it all. When colorectal cancer spreads to the liver, fewer than 1 in 4 patients are actually eligible for surgery when they're first diagnosed. That's a huge number of people left needing another way forward.
And the main roadblock comes down to this one crucial concept, the future liver remnant, or FLR. See, the liver is amazing. It can actually grow back. But if a surgeon has to remove a huge chunk to get all the cancer out, the little piece left behind, that's the FLR, might not be big enough to do its job. That could lead to liver failure, and that risk is exactly what makes so many patients unresectable.
But this is where things get really cool. This is where medical ingenuity shines. If the healthy part of the liver is too small, the question becomes, what if you could make it grow before the operation? And that is the whole idea behind a procedure called portal vein embolization, or PVE.
Honestly, it's a brilliant piece of biological hacking. Here's how it works. First, doctors go in and block the blood supply just to the parts of the liver that have cancer. The body then, completely naturally, reroutes all that blood flow over to the healthy, cancer-free side. Well, what happens when you feed something? It grows. Fueled by all this extra blood, the healthy remnant gets a powerful signal to grow, and it can grow by a massive amount. After a few weeks, it's big enough to safely take over, and the surgeon can finally go in and perform what was once an impossible surgery.
So PVE followed by liver resection, we'll call it PVEFL, is a total game changer, but it's not the only trick in the book. So now let's get to the heart of this review and see how this technique really stacks up against some of its main rivals.
Just to give you some perspective, this chart shows how those 2022 patients in the review were treated. See that long bar for PVFLR? It was used in almost 40% of these complex cases. That makes it one of the most common strategies out there, right behind just a simple, straightforward resection. And because it's so common, we really need to know how it compares to the other options.
Okay, first up, PVFLR versus a newer, much more aggressive technique called ALPES. You can basically think of this as the tortoise versus the hare. PVFLR is our tortoise. It's a slower, steadier, and less invasive way to get that liver to grow over a few weeks. ALPES, on the other hand, is the hare. It's a super aggressive, 2-part surgery that forces the liver to grow incredibly fast, in like a week. So who wins this race?
Well, when you look at the finish line, overall survival, the results are pretty surprising. This table shows that even with these radically different approaches, there was no real winner. Patients in both groups lived for a median of around 30 months. So the fast and furious approach didn't actually lead to a longer life than the slow and steady one.
But, and this is a huge but, survival isn't the whole story. What about safety? This is where the story takes a sharp turn. Look at the data on complications after surgery. It is absolutely striking. The more aggressive ALPS procedure had a complication rate of 65%. That's more than double the 27% for PVFLR. And this wasn't just a fluke. It was a statistically significant difference.
All right, next up, let's compare PVFLR to what some might call the ultimate fix, a full liver transplant. In this case, you're not trying to save a piece of the patient's liver, you're replacing the whole thing. It's like the good, established technique versus what could be the perfect, curative one.
So when it's an option, a liver transplant offers a huge survival advantage. Let's just focus on the data here for patients with a really high amount of cancer. For them, a transplant offered a median survival of over 40 months. Now compare that to just 19 months for the PV-FLR group in the same situation. That is a massive, life-changing difference.
Okay, so if it offers superior survival and even a slightly lower complication rate, why isn't everybody just getting a transplant? Well, here's the catch, and it's a huge one: donor availability. This incredibly powerful option is only available to a tiny, tiny fraction of patients who are lucky enough to get a matching organ. For pretty much everyone else, it's just not on the table.
Okay, so we have one option that's safer than ALPS, but another that's less effective than a transplant. So what's the final verdict here? What does all this evidence really mean when it's time to make a decision?
Well, first, we have to be good scientists about this, and the authors of the review certainly are. They are very clear about the limitations of the research we have so far. A lot of the evidence comes from smaller studies, not those big, gold standard randomized trials. And that just means we have to be a little cautious. We can't just declare one method the absolute winner for every single patient.
And that really brings us to the true conclusion of this review. The authors say it perfectly right here. The choice of technique should be individualized. There is no one-size-fits-all answer. What we have is a toolkit, and doctors have to pick the right tool for the job based on the patient's specific anatomy, how much cancer they have, and frankly, what that particular hospital is really good at.
So let's zoom out for a second. What's the big picture takeaway from all of this? Why does a review like this and a technique like PV-FLR actually matter so much?
It really comes down to this simple but incredibly powerful fact. PV-FLR takes patients who were once told, sorry, there's nothing more we can do with surgery, and moves them over into the candidate for a cure category. It literally expands the pool of hope. It's a widely available, relatively safe, and effective bridge that gives so many more people a shot at the treatment they desperately need.
And that really leaves us with a final thought to chew on. We've seen how PV-FLR builds a bridge to surgery. We've seen other techniques pushing the limits in different ways. The review even suggests that the future is in combining these methods with things like chemotherapy or immunotherapy. So the question that's left is this: as we keep getting better at refining and combining these incredible techniques, just how much closer can we get to a cure for everyone?